Great. Welcome, everyone. Let's go ahead and get started. So I'm Wei San, one of the hosts for Virtual Global Spine Conference. And today I'm really excited to welcome my friend, Yang. Dr. Yang hails from Canada, and despite that, has established himself in a very quick amount of time to be a leading expert in spine surgery, and particularly in the realm of enhanced recovery. So I've asked him to put together some different points of ERAS, and super grateful for it. I'll let you take.
Great, thank you, Coy. Can everybody hear me okay? Oh,
yes.
Okay, very good. So my name is Michael Yang. It's a pleasure being here. Thank you, Dr. Tham, for inviting me to this virtual global spine conference. I'm a clinical assistant professor and spinal neurosurgeon here at the University of Calgary. And the topic of my discussion today is Enhanced Recovery After Surgery Program in Lumbar Fusion Surgery. These are my disclosures, none of which is relevant to today's talk. So this is the brief outline for today's talk. Number one is, what is ERAS? What is the evidence? But I'm going to spend the majority of time for today's talk talking about our ERAS protocol at the University of Calgary and the impact of some of the ERAS elements on outcomes. And we'll discuss our ERAS protocol over a case. So we spend, millions of dollars each year in the US and Canada purchasing enabling technologies such as intraoperative 3D C-arms, navigation units, robotics to help us place more accurate pedicle screws, and even, augmented reality to help us plan our surgical approaches and plan complex surgeries and deformity and tumor surgery, for example. While I'm a big supporter of introducing enabling technology into the operating room, I feel like the money invested in these technologies is not really directly proportional to improving the outcomes that patients actually care about. So I propose, what if we only spent a fraction of this money on just organizing healthcare better, in applying evidence-based medicine and optimizing patients in the preoperative period, perioperative period, and post-operative period. And in my opinion, by doing this, we're able to improve patient outcomes that patients actually care about. That includes improving pain control after surgery, reducing medical complications after surgery, enabling them to go home faster, reduce length of stay, reduce healthcare costs, as well as maybe even improving functional recovery so that they can go back to work and go back to school much earlier. And in my opinion, enhanced recovery after surgery programs is able to do just that. So what is ERAS? So ERAS is a term coined by Henrik Kelle, who is a general surgeon in the 1990s. And it is an evidence-based multimodal transdisciplinary care improvement initiative to promote recovery of patients undergoing surgery throughout their entire perioperative journey. In any ERAS protocol that you read, and it's been published and implemented in many surgical specialties such as colorectal, cardiac surgery, pediatric surgery, as well as now in spine surgery as well. In all these protocols, the goal is to facilitate patient recovery, reduce length of stay, as well as reduce perioperative complications after their operations. So this is a typical phase of care that patients often go through their surgical journey. It includes, being seen in the clinic, a preoperative phase, a perioperative phase, as well as in the postoperative phase. The y-axis is basically the patient's physical status, you can say. So if you compare a patient undergoing traditional care, in the preoperative period, you're starving them because potentially you're doing NPO at midnight, you're not giving them carb load, you're not using local regional block techniques in surgery, you're doing maximally invasive surgery. So these patients really take a big hit when they do undergo surgery. In the postoperative phase, you're leaving drains in, leaving the Foley catheter in. Patients are afraid to get up and move, so they're laying in their hospital beds for an extended period of time, and their recovery just takes much longer to recover back to their baseline. Versus in patients undergoing evidence-based ERAS care, you're really trying to reduce the time before they reach back to their baseline. So in the preoperative phase, we'll often minimize the amount of time they're NPO. We get them to drink a carbohydrate drink like apple juice or orange juice. They really switch them from a catabolic state to an anabolic state. We give them preemptive analgesia like Tylenol or ibuprofen before surgery to reduce postoperative pain. We use regional blocks in surgery. We use minimally invasive surgery techniques. We minimize the use of drain Foley catheters and encourage them to mobilize. All these efforts trying to reduce the impact of surgery on the patient itself. With all these ERAS goals, we try to minimize or reduce surgical stress on the patients as much as possible, as well as maintain physiological homeostasis. So what are some of the evidence? So this is an article published out of France by Dr. De Bono. This looked at a pre-post implementation of the ERAS pathway in 3 different groups: ALIF, ACDF, and posterior lumbar fusion in around 1,500 patients. And they found that the length of stay in this patient population was significantly less in the ERAS phase, around 3 days versus 6.6 days in ALIF, for example. In every 3 of these different surgical procedures, length of stay was much improved. In terms of patient satisfaction, they also found that patients' overall satisfaction was also in the 80% range in the ERAS protocol versus a much lower score in the pre-ERAS phase. When they looked at complication rates for these procedures, they didn't find any difference in ALIF or ACDF, but they did find a reduction in postoperative complication and revenge surgery at 90 days. Another study by Dr. Wang and the University of Miami in doing ERAS protocol in the minimally invasive TLIF procedure versus conventional TLIF, they found that they also reduced the length of stay by almost 50% and was able to have a cost saving approximately $3,400 per case, which is a 15% cost reduction. So prior to this, people were doing their own ERAS protocols, and there was no really defined protocol for ERAS. The ERAS Society is an international organization that was tasked to publish these consistent statements for ERAS for institutions to implement. And in 2021, they issued and published a ERAS guideline on lumbar fusion surgery. There was 22 different ERAS components, 28 different recommendations, 8 in the preoperative, 8 in the intraoperative, and 5 in the postoperative period. So the University of Calgary were actually one of the centers that took this guideline, and I was one of the authors, lucky to be enough, one of the authors on this guideline, to try to operationalize this guideline and put it into practice. So at the University of Calgary, we defined lumbar fusion surgery as short segment lumbar fusion procedure less than equal to 5 levels, has to be T10 or below, no stage surgery, no cancer-related surgery, and elective surgery only, because we want to have the opportunity to optimize the patient before their operation. This is our length of stay data for our lumbar fusion patients prior to the implementation of ERAS. Our mean length of stay was 4.9 days. Median length of stay was 3.3 days, and only 42% of patients were discharged by postoperative day 2. We also found that there was significant amount of surgeon variability within our institution. We have 12 spine fellowship trained spine surgeons at the University of Calgary. It's a mix of ortho and neurospine. And this is hospital stay data by surgeon in the x-axis and length of stay in the y-axis. You can see that with using the same case definition, there's a wide variability in length of stay amongst even our group from 2.1 days on average up to 7 days. So we really wanted to try to reduce the variability of care, to try to tighten up this variability of outcomes in terms of length of stay. This is the percentage of patients discharged by postoperative day 2. You can see that there are 3 surgeons within our institution that has more than 70% of patients discharged by postoperative day 2, but there are also 3 surgeons that has never had a patient go home in the first 2 days after surgery. So this really begs the question, why is that? Why are there some surgeons that perform better than others? And is there a way to try to reduce this variability of care even within our institution? At our institution, we have a goal of trying to discharge these patients, 70% discharged by postoperative day 2. And that's something we're trying to achieve through our ERAS program. So I think one of the reasons why there's variability of care is because there's a lot of variability of how we take care of patients in the preoperative and in the perioperative period. We actually audit all our lumbar fusion patients, and these are all of the ERAS elements that are important. And when we first started, this is prior to implementation of our ERAS program, we found that about 50% of the ERAS elements, we had a compliance rate of less than 80%. So a lot of improvement that needed to be done even within our institution. So for example, ERAS education, we didn't have an ERAS educational program prior to our launching. So we only have 4% of patients being compliant for ERAS education. So I want to share with you what are some of the elements within the ERAS protocol at the University of Calgary, and I want to do that through a case. So this is a 60-year-old obese female, BMI of 55, 325 pounds, presents with 20-month history of progressive right leg pain and low back pain, and cannot walk more than 200 steps per day. Aggravating factors including walking, sitting, and standing, and alleviating factors including being in a flex position or lying down. On examination, there was no motor weakness, reflex was 2+ throughout, and there was numbness in the lateral aspect of her thigh, and she walks in a flex position leaning on a walker. Conservative treatments that she's tried in the past include ESI, nerve root blocks, and physical therapy, none of which worked. And this is her pain diagram, having really a radiculopathy in the L5 distribution. So we also perform a preoperative questionnaire in all our patients. So we find that this patient is a daily opioid user, complains of NRS back pain of 8 out of 10, NRS leg pain of 9 out of 10. PHQ-9 is a depression score. Anything greater than 10 is considered clinically depressed, and this patient scored a 15. There was no history of post-operative nausea, vomiting, or motion sickness in this patient, and the patient is a non-smoker. And this will become relevant a little bit later on. So this is the preoperative imaging. You can see that there's a spondylolisthesis at L5-S1, and there's a dynamic component with flexion and extension views. And this is the MRI. When the patient's flat, the spondylolisthesis actually reduces back to neutral. You can see that there's significant amount of joint effusion at the L5-S1 disc space, a lot of soft tissue, a little bit of sarcopenia, felt infiltrating into the paraspinal muscles. And you can see on the right side of foramen, there's a significant neuroforaminal stenosis at the right L5-S1 level, causing compression of the L5 nerve root. So the patient has a L5 radiculopathy secondary to the neuroforaminal stenosis. This is the CT scan showing, a vacuum disc phenomenon at L5-S1, and then again, widened joint space at the L5-S1 facet joint. So our surgical plan for this patient was a right-sided L5-S1 MIS TLIF with percutaneous instrumentation. So I guess question for Koya and whoever is online is, how would you optimize this patient in your institution prior to subjecting them to surgery? Is there any protocol that you guys use at your institution? Okay, well, I think Koya is potentially preoccupied at this point, but I'll go forward with the presentation. So we do a significant amount of preoperative optimization at the University of Calgary. So first and foremost, the most important thing is having preoperative ERAS education. So this is a pamphlet that we give to patients who are undergoing lumbar fusion surgery. We describe what is ERAS, what are things that they should do before surgery to prepare for their operation, including exercising regularly, eating a healthy diet. We really emphasize the importance of alcohol cessation, and our target is less than 2 drinks per week, 1 month before surgery. We want them to stop smoking at least 1 month before their operation. As we know, smoking increases the risk of wound infections as well as pseudoarthrosis in lumbar fusion patients. We also inform that they may be seen by internal medicine or anesthesia prior to their operation. We also educate them on what is expected before surgery. They may be asked to stop eating or drinking hours before, get a carbohydrate load. They may get preemptive analgesia, et cetera, et cetera. And also the post-operative protocol in terms of when they should be expected to eat, what kind of medication they will be receiving, when should they be getting up and move, and whether they're going to have any tubes or drains and when that should be removed. These are the QR codes, and you're free to access this PDF file. We also have some videos online of what ERAS surgery is, and patients can watch this in preparation for their operation. So back to our patient a little bit. So we also want to determine the risk for developing poorly controlled pain after surgery in all our lumbar fusion surgery patients. So we published a paper in JNS a couple of years ago, developing a clinical prediction score, and we were able to determine the risk of a patient developing poorly controlled pain as defined as an NRS score of greater than 4 in the first 24 hours of surgery. We found that there were 7 different risk factors for poorly controlled pain. So younger age, female sex, daily preoperative opiate use, increasing back pain, especially greater than 7, moderate to severe depression, greater than 3 level of surgery, and fusion surgery. And each of them are assigned a point associated with it. And daily preoperative opiate use is the most significant and most important risk factor for a poor postoperative pain control. So for our patient was 60 years, so we'll get a point of 2. Sex is female, so another 2 points. Daily opiate use, so 3 points. PHQ-9 at 15, so 1 point. We're only doing one level surgery, so not a greater than or equal to 3 segment surgery, so 0 point for that. And we're doing a fusion surgery, so 1 score for that. So out of a score of 14, the patient scores 10 out of 14. And in our score, this puts the patient in the extreme high risk group, and there's an 85.1% of poor postoperative pain control after their lumbar fusion surgery. So for this patient, we want to put in a lot of effort to try to optimize their pain so that they don't experience poorly controlled pain after surgery. Why is this? Some surgeons may think, oh, pain after surgery, that is expected. I don't really care about that, but maybe we all should. This is a paper we published just this year, correlating whether poor pain control in the first 24 hours of surgery impacts poor surgical outcomes in terms of ODI or NDI at 2 years. And we found that patients with poorly controlled pain in the first 24 hours was much less likely to reach MCID in terms of clinical improvement on ODI or NDA at 2 years. So the patient had poorly controlled pain in the first 24 hours. They were at a 2.3 times increased odds of failure to achieve 30% improvement in ODI if pain was poorly controlled. So this gives you even more, should give us pause and make us really think about the importance of controlling pain in patients undergoing spinal surgery. So what was our analgesic plan for this patient? We gave him preemptive analgesia 1 hour before surgery. And in our institution, we give celecoxib 400 milligram PO times 1 and acetaminophen 1 gram times 1. Intraoperatively, we did regional blocks. So we did fluoroscopic guided erector spinal plane block. And we basically use a spinal needle and we target the TP of L5. And we inject 10 cc's of 0.25 bupivacaine with epinephrine in both of the TPs. And this is supposed to block the ventral and dorsal rami to try to improve postoperative pain. Postoperatively, we definitely use multimodal analgesia. Our acetaminophen is scheduled for the patient every 6 hours. We also give ketorolac 15 milligrams IV Q8 hours for the first 48 hours. And we regularly schedule this. I know there's a lot of controversies in the literature on whether NSAIDs will impact fusions. And there is evidence of if you use NSAIDs for a long term, there's a negative impact on fusion rates. But let's remember that poor postoperative pain control is the worst in the first 48 hours. And if you treat, giving ketorolac for the first 48 hours when the pain is worse is not going to have a significant impact on their fusion rates in 6 months or 1 year. Anesthesiologists often give them a big whack of, 8 milligrams of dexamethasone during surgery for PONV or postoperative nausea and vomiting prophylaxis. So the anti-inflammatory effects of dexamethasone is way more than ketorolac, in my opinion. We also give them hydromorph PO and as well as IV on a PRN basis after surgery. So this is some of our local data and how preemptive analgesia has an impact on length of stay. So y-axis is length of stay, and this is for single-level surgery, and this is multi-level surgery. And these numbers are the length of stay. You can see that the patients who receive preemptive analgesia, and we define that as having at least one agent prior to surgery, so either Tylenol or celecoxib or both. You can see that the length of stay for patients undergoing multi-level fusion, there's a difference of 0.7 days, and in single-level surgery, there's a difference of 1.4 days just by giving them preemptive analgesia. So I touched a bit about erector spinae plane block. So what is that? That is really a plane between the transverse process and the erector spinae muscles. And traditionally, ESP blocks are done using ultrasound guidance, which can be quite tedious and time-consuming. But the goal is to try to block the dorsal and ventral rami of the lumbar spinal nerves, which provides the nociceptive innervation in this area. So by blocking these nerves, we're able to really significantly reduce postoperative pain. And there's been multiple RCTs showing that postoperative pain is superiorly more controlled in patients undergoing ESP block compared to placebo. In our practice, we don't have easy access to regional anesthesiologists to do these blocks for us. So we do this under AP fluoroscopy. And and studies have shown that it is really quick and very easy to do this under fluoroscopy. We just take our C-arm in the AP position. We basically, again, target the transverse processes, and we inject local anesthetic. And on average, it only takes 1.2 minutes to complete this under fluoroscopy versus under ultrasound, which can take up to 10 minutes or 9 minutes to do a ESP block. So very, very surgeon-friendly. We also ensure that we optimize the patient for postoperative nausea and vomiting, and we use the AFO score to risk stratify patients, and these are the risk factors for PONV. So female sex is given a score of 1, non-smoker is given a score of 1, and if you anticipate any opioid use, which is pretty much everybody in lumbar fusion surgery, you give 1 point. History of PONV or motion sickness is 1 score. So as with increasing scores, you have increasing risk of developing PONV in the postoperative period. So for our patient, she was female, and we anticipate use of postoperative opioid use, so she would be considered having a 39% risk of developing PONV. So in our institution, we define we would give PONV prophylaxis in any patients who score greater than or equal to 2 on the AFO score, and they receive 2 or more agents either in the preoperative phase or the intraoperative phase. So these are some of the agents that we commonly give: eripipritant, dexamethasone, ondansetron, haloperidol, or metoclopramide. So when we look at our own data in Calgary, we see that in patients getting the PONV prophylaxis, if they're high risk, there's also a significant impact on their length of stay. So for multi-level surgery, it was 4 days versus 5.9 days in multi-level surgery, versus in single-level surgery, it was a 0.5-day difference between those who were compliant on the PONV prophylaxis versus those who are non-compliant on the PONV prophylaxis. We also do a bunch of preoperative anemia screening, and we look at any prior CBC performed between 1 year and 6 weeks. We define anemia as having a hemoglobin less than 120 and a ferritin of less than 20 for males and less than 30 for females. And we try to target a hemoglobin of greater than 130 if they are iron deficient. And we do that with oral iron supplementation if we have time to optimize them. It usually takes around 6 weeks of therapy. If we don't have that much time, then we give them IV therapy. It's 1 to 1.5 gram total dose. And you should really wait for 3 weeks for their maximal effect. We also ensure that we apply modern fasting guidelines, so not to fast them too much so that they're in a catabolic state during their surgery. So so the recommendation for us is 8 hours for meals, 6 hours for a snack, 2 hours for clear fluids. And there's been an increasing use of GLP-1 agonists in the community for weight loss purposes and for diabetes management. And this has increased the risk of aspiration risk in any surgery, actually. So the American Anesthesiology Association recommendation has really you should try to stop the GLP-1 agonist therapy a day before if they're on a daily dosing regimen, or 1 week before if they're having a weekly dosing regimen. And this is just to try to reduce the risk of aspiration during the intubation process. We also give them a carbohydrate load 2 to 3 hours before surgery with apple juice or cranberry juice. There are proprietary carbohydrate load formulas out there, but being in Canada, we don't have funding for such drinks, so we just ask them to drink apple juice or cranberry juice. We also ensure that patients have a bear paw placed on in the preoperative period to try to really reduce the risk of intraoperative hypothermia, which has been associated with increased SSIs after surgery. And we also avoid preoperative sedation using benzodiazepines. So another question for Koi or anybody who's online is, was there any intraoperative strategies that you do or you use to utilize to try to facilitate and improve patient recovery in your practice? Okay, seeing that there's no ERAS people in the audience, I'll continue with the talk. So in the intraoperative phase, I think one of the tenets of ERAS is try to reduce the surgical stress on the patients. So that's why minimally invasive surgery, I think, in my opinion, it really aligns with the ERAS concept to try to reduce tissue trauma, reduce blood loss, and things like that. So we performed a right-sided L5-S1 MIST lift with perc screws. So again, minimally invasive surgery, the patient's obese. So we were able to really minimize the amount of tissue dissection and really just targeting the pathology of interest and doing the fusion that way. We also do, we should also do regional blocks. So in our case, we did an erector spinae plane block, but there are also other blocks out there, such as thoracolumbar interfascial plane blocks or intrathecal morphine injections to try to reduce postoperative pain. We also use active force air warmers during the operation to try to reduce intraoperative hypothermia, as well as heated IV fluids. We also ensure that we do fluid-directed therapy, meaning that we don't want to over-fluid load the patient during the operation so they become, they increase the risk of pulmonary edema or increase water weight so that they don't mobilize as well after surgery. But we also don't want it to be too dry, so to increase the risk of AKIs and things like that. So we keep our fluid balance for our patient between 500 and 2,000 cc's. We also try to avoid the use of Foley catheterization, and if used, we try to discontinue them prior to the patient leaving the operating room. So we really shouldn't be using Foley catheters if you expect the surgery to be done within 3 hours at a time. And this is some, again, our length of stay data based on whether Foleys are removed by post-operative day 0, which is defined as 7 a.m. the next day. So patients who have their Foley catheter discharged by 7 a.m. the next day, for a single level surgery, their average length of stay is only 2.9 versus 5.3 if their Foley is kept beyond 7 a.m. the next day. For multi-level surgery, the difference is even more stark, 4.1 versus 8.1 if they're kept more than 7 a.m. the following day. We also discourage the use of surgical drains, and they really shouldn't be used, especially in low-risk patients, such as people who have no risk of coagulopathy, for example. There are many RCTs out there, or many studies out there that shows that putting a surgical drain does not actually reduce the chance of epidural hematoma that require reoperations. Some of those studies are not adequately powered, but there are a lot of evidence that suggests that it does not make a difference in terms of epidural hematoma formation. Speaking to some of our surgeons here, they say, "Oh, why put a drain in? Because it makes my dressing looks nicer. There's less seeping of the drain of seroma or whatever, and doesn't soak my dressing as much if I put a drain in." And recently there was a RCT that was published about drain use, and they found that there was no difference in the drain group versus non-drain group in terms of saturation of their dressing. So if you're putting a drain in there just to make the dressing look nicer, difference from a recent randomized controlled trial. And when we look at our length of stay data, again, for those who don't have a surgical drain versus who do have a surgical drain, you can see the stark difference again in length of stay. 2.7 in those that don't have a surgical drain placed versus 5.2 for single level surgery, and 5.0 for multi-level surgery, and 6.2 in the non-compliant or patients who had a surgical drain. So in terms of post-operative optimization, we also do a lot. So we also make sure that the patient have multimodal analgesia, and in our ERAS elements and the ERAS guideline is that the patient just needs to have 2 different classes of analgesia. So this is a very low bar to satisfy. So as long as the patient's on Tylenol and hydromorph, that will actually satisfy the ERAS guideline recommendations. But in our institution, we use at least 3 agents. That includes an NSAID, Tylenol, as well as hydromorph medication. We also give patients muscle relaxants, more specifically gabapentin in our case. In terms of opiate medication usage, we should all be given oral medications first prior to IV analgesia because they work better for acute postoperative pain. And PCA should really not be used in the management of postoperative pain after surgery in general, because these patients are usually tied to the bed with the PCA pump. It's hard to mobilize with the PCA pump, and their pain is often not as well managed as if they're just on an oral regimen. Patients should be on a PONV medications postoperatively, and should use a different class of medication as compared to the PONV prophylaxis. At the University of Calgary, we actually regularly scheduled ondansetron for the first 48 hours after surgery, regardless of their nausea score, because we feel like any type of nausea vomiting, especially with opioids, can really hinder patients' recovery. In terms of VTE prophylaxis, mechanical prophylaxis should be used as a minimum. Chemoprophylaxis may be for higher risk patients, but definitely not mandatory. And early mobilization, in my opinion, is one of the most important things that patients can do to try to enhance their recovery. And we place a lot of effort in encouraging patients to mobilize after surgery. So we have a whole educational pamphlet, what to expect after surgery, how much they should be walking after surgery. We have distance that are pre-measured in our units to figure out how far the patients have been walking. We have given tracking sheets so they can track how much they have walked or time out of bed. We have a huge QI project about trying to mobilize patients, patient stickers on the wall to try to give them an idea of how far they have walked. This is our mobilization protocol at the University of Calgary. We want them on day 0, so within 8 hours after surgery, to ambulate assisted or unassisted for at least 10 meters. On day 1, ambulate 20 meters and be 4 hours out of the bed. And post-operative day 2 onwards, we want them to ambulate 30 meters or 6 hours out of bed. And you can see this is our crude results of the mobilization data. We have a lot of missing data because it's difficult to document mobilization. But for those who are compliant with post-op day 0 mobilization with this criteria, the average length of stay for single-level surgery is 2.5 versus 6.3 in the non-compliant group. In multi-level surgery, it's 3.5 in the compliant group and 9.2 days in the non-compliant group for the multi-level surgery. So again, significant difference between the length of stay if you were just to get up and walk within 8 hours after surgery. So very simple things. So back to our patient. So this patient went again, right-sided L5-S1 MIST lift. His mean pain score in the first 24 hours after surgery was only 4. Time to first ambulation for this patient was 7 hours, even though he was 325 pounds. He was discharged on day 1, no readmission, no complication, had a complete resolution of his right-sided leg pain at 3 months when I saw him at follow-up. And this is his post-operative x-ray. So these are the 22 elements in ERAS. And, if Clay would probably think that these are pretty basic things, right? What you're saying, give patients pain medicine, make sure we don't starve them, get them up and walk, take out the Foley. Seems pretty basic, and he's probably already doing ERAS in his practice. But I will argue that if you're not auditing your practice, you are actually not doing ERAS properly. You need to know how compliant you are on each of these elements, and you need to do continuous improvement to try to improve that, such as how we're doing it at the University of Calgary. So obviously, tracking all these data is very, very labor intensive. So at the University of Calgary, we have actually automated a lot of our data extraction through Epic. So we actually mapped all the discrete fields within Epic, and we're able to extract 90% of our data fields from Epic directly into a Tableau data visualization field, which gives us just-in-time information. And we're able to get refreshes of our data pretty much on a daily basis in terms of how we're doing in terms of our compliance. We still have about 10% of our data that needs to be manually extracted, but we're working towards trying to minimize this even further so that we can automate this entire auditing process. So what we do, that's something different probably compared to a lot of other institutions, that we actually give surgeons, all 12 surgeons here, a biannual surgeon report card. So we will show, for example, this is my data, how I'm doing for education, preoperative, anemia screening, carbohydrate loading. How am I doing, and how are you compared to your peers? We also give give them their complication data, their length of stay data, and they can really start to see, am I in line with my peers, or am I doing poorly? Where am I doing poorly? Which aspects can I really get better on? So we're giving surgeons an opportunity, even within their practices, to try to improve what they're doing, to really try to standardize their care for patients going forward. So we do this on a biannual basis. Most surgeons are very receptive to this. It's all anonymized, but they get their own personal data compared to their peers. So we create some sort of competition within the division to try to encourage continuous improvement in our organization. So with this data, it's very important to do regular reviews of your compliance metrics. We have biweekly team meetings. We've identified problem areas where we need to put more effort into to try to optimize our compliance metrics. We also identify high areas of non-compliance, and we create targeted QI projects to try to improve those non-compliance items. So some of the QI projects we're working on right now is early mobilization, early removal of Foley catheters, as well as the creation of a more comprehensive preoperative education videos so that patients can be more of a partner in terms of the recovery and being engaged in their perioperative recovery process. So ERAS is not a surgeon's program. As you can see, surgery is only a small portion of the ERAS pathway. You really need to build a team to really help you implement ERAS at your institution. So we have a really big team at the University of Calgary. I'm the neurospine lead. Dr. Peter Laconia is the orthopedic spine surgeon on the ortho side. We have an anesthesiology lead, Dr. Kyle Rogan. We have a QI specialist on our team to try to, make sure we're doing our QI improvements in an evidence-based way. We have an operational manager. We have an ERAS nurse educator. We have a data analyst that puts together our QI compliance information. We have a research coordinator. Everything that we do in ERAS is associated with the research project so that we can actually measure improvements and hopefully publish that data in the future. And we also recently hired a ERAS nurse navigator that actually sees these patients, before their surgery to provide education, and also follows up with them in the post-operative period to ensure that their pain is well controlled. They're getting up and walking around, their Foley and their drains are removed in time. All that stuff to try to improve our compliance measures. So in summary, ERAS programs, in my opinion, can really have a significant impact on patient outcomes. And it's really the outcomes that patients care about: improving pain, getting out of the hospital earlier, and recovering from their surgery so they go back to doing what they love to do sooner. So going back to work, going back to school, doing their daily jobs, things like that. To do ERAS means that you have to audit your performance. Having a post-operative order set with some ERAS elements is not enough. You really need to spend the time to audit your performance, and that is not easy, and that's why most people don't really have a true ERAS program, in my opinion. And you need to build a team. ERAS, again, is not a surgeon's program. You need to build a comprehensive team that all have a common goal of trying to improve patient outcomes, and together as a team, you will be able to see success in implementing a successful ERAS program and having a positive impact on patients. So that concludes my talk, and I'm happy to take any questions that you may have. Thank you.
Thank you so much for the great session, Dr. Yang. Dr. Yang, we have a question on the chat box. Hello, Dr. Yang.
Sorry, did I get kicked out?
Now we are fine.
Perfect.
Yes, Dr. Yang, can you hear me?
I can hear you, yeah.
Yeah, we have a question on the chat box.
Sure. What is the question? I can't really see.
Okay.
I kind of got kicked out, so I kind of kicked out, so I don't see the question. Can you read it for me?
Sure. Yeah, the question is about from Jay. He said, you did mention multiple regional anesthesia techniques. How often did you use other techniques apart from ESP block?
To be honest, I mainly use ESP blocks because most of the TLIP blocks were intrathecal morphine. I never tried. I know there are randomized control trials showing that intrathecal blocks are very effective and have very low complication rates, but I personally have not tried that before. I worry about urinary retentions and things like that, or respiratory depressions. But because of ease of use, I've been using ESP blocks because I can do it under fluoroscopy and I have total control of that. So I usually do the ESP blocks after the patient is asleep and prepped, so I can do it within a minute, and then that's it. I even do it for all my open lumbar decompression procedures and any type of lumbar surgery, actually. So it's because it's so fast, and you really have good impact on patients' post-operative pain control.
Thank you so much. We have another question. what
Sure.
barriers do you see most common at the hospital for ERAS?
Yeah, I mean, ERAS is about organization, and it spans multiple stakeholders. So from the preoperative period to the intraoperative period, so anesthesiologists and the post-operative unit nurses. So you really need to implement a program. You need to get, collaboration and people on board early on and really sell them on your overall goal of trying to improve patient outcomes through these measures, because everybody has their own agenda, everybody has their own priorities. So how can you convince these stakeholders that what you're doing is important? So for example, for us, mobilization is very important, but the unit nurses are so busy. They have to give medications. They have to, make sure the chemical DVT profiles are given. They have to ensure all the MARs are attached. You have to document the notes. And we're telling them, can you please, on top of doing everything that you do as a nurse, can you please walk them and document them in the right place so I can see that they've walked? So how do you do that? That is the biggest challenge, is to convince others to do what you want and what you think is valuable. And our strategy has been to do monthly meetings with these unit nurse managers. We actually give them report cards. We show them how their unit is doing compared to other units. And we show them how, show our data, the data that I've showed you today, like mobilizing patients on day 0 actually impacts length of stay. And there's a very significant difference. So we're hoping that they will jump up with data kind of thing. And having sufficient resources. So we have an ERAS nurse that is doing a lot of this work for us. So we're very lucky to have that resource and that funding to hire this ERAS nurse. So, but it's still doable even if you don't have this ERAS nurse. It just may be a little bit more difficult. You do need also have a champion. You need someone that really believes in ERAS to really push this. Yeah.
Thank you very much. That was great. Thank you. We don't have more questions. Great insights. Thank you, Dr.
Awesome.
Yeah.
Great. Well, thank you very much for your attention.
Thank you. We will post the recording on our YouTube channel, and we will post the next Thursday session on our social media channels as well. Thank you all for joining.
Great. Thank you.
Thank you. Bye.
Bye.